Hi everyone and welcome to this case presentation on anterior aesthetic rehabilitation with direct nanohybrid composite resin. So today what we're going to discuss is not going to be very theoretical in aspect. We're going to keep it as much practical and clinical oriented. So when you get those neat questions on application based kind of a scenario, you need to be well versed with this. And this presentation is also going to be very helpful for your day-to-day clinical direct restoratives, and it is also going to be very useful for the clinicians to get a good hold on their skills and the different steps involved in restoring an anterior segment with direct composites using this nano hybrid composite resin, right? So let's just start off with this case. So there are different ways of approaching an anterior case, right? So when there is some kind of an aesthetic rehabilitation required in the anterior segment, you have different materials you can choose from, different techniques you can choose from, and different kind of skill sets that you can have. So let's just do the treatment plan for this patient. So you can see that has an old composite filling in the mesial aspect. That is a class 3 mesial composite resin, which has been extended over the facial aspect. There's also a restoration that has been dislodged with respect to 2-1 and also 2-2. So I'll show you the different views of the same. You can see that 2-2, the distal half is gone and it's almost still the cervical level, because of which it also had to undergo an endodontic treatment. That is for the lateral incisor in the second quadrant, after which it was restored with direct composite in this case. We are going to treat right from 1-3 to 2-3 because you can see there's some amount of surface alteration. So let's just get my pointer out over here. You can see that there is some amount of surface alterations in the mesial side, which can be just polished a little bit, roughened and restored with some composite resin, nicely polished so we get a good gloss at the corner of our smile line. We also have some amount of decay that you can see in this mesial aspect of 1-2 and of 2-2 as well. You can see that the distal half of 2-2 is involved. You can see that there is a restoration which has been discolored, and there is some amount of marginal leakage across the margins of this restoration. And there is obviously a dislodged restoration and secondary decay with respect to 2-1. So in such a case, what would be your treatment option? So you can either go with a crown for 2-2, a composite restoration for 1-1 and 2-1, followed by veneers in order to close this gap a little bit. You can even give a very superficial kind of a prep and go from canine to canine to restore the smile line back to what you call as aesthetic smile. You can see the smile line as well slightly drooping over the lower lip, right? So it's slightly overlapping the lower lip, which is how her overjet is, her overbite is. So there's not much you can do about that. But obviously, you can correct these line angles and give them a good kind of a camouflage so that they look more aesthetic. Also, the midline needs to be corrected in this case. So let's see what can be the different options. So I gave the options of ceramic veneers. I gave the option of a little bit of orthodontics followed by restorations. I also gave an option for a crown with respect to 2-2, and these were the different options of ceramic veneers, crowns, and all that were discussed with the patient. The patient's consent was obtained, and the patient was looking at a more economical kind of an alternative, which can be done in a single visit or two visits with minimal intervention of the healthy tooth structure. So in that case, we go with a direct restoration. Indirect restorations, you all know, require more amount of tooth preparation, require couple of visits. That is, it requires at least two visits for the basic prep and the cementation. Otherwise, you may have to even add appointments for mock-up, right? So in this case, what we did was a direct restoration using a direct nanohybrid composite resin known as Solar Sculpt from GC company, right? So in such a case, you can see that in this image, I have done a pre-operative evaluation under the microscope. So there's a microscopic photograph of the anterior segment again. If we look in the microscope, we can see the decay much more clear. We can see the surface alterations more clearly. It gives us more amount of illumination and magnification to our working site, which is extremely crucial in understanding the present status, the current status of the smile. So after which I just isolated this area using rubber dam. We all know that rubber dam isolation is absolutely required. But before rubber dam, what I did was with this natural light, I used my shade tab and selected A2 shade as the shade to be used during the composite restoration, right? It is very important that we do it in natural light, as the dehydrated enamel or enamel in a different kind of a light source can affect the shade matching, right? So you can place small globules of composite. So you can just take a little bit of composite, do a little bit of spot etching, or you can just place it over the teeth with a little bit of bonding agent and cure it for about 5 to 10 seconds, and you'll get the exact shade. So you can use probably A3 over here, A2 over here in the middle third, and A1 or different kinds of B2, and all those shades placed over here. And then you can then select which shade is corresponding to the tooth the most, right? So then we isolated after shade selection. We were under magnification through Carl Zeiss microscope. We could see the secondary decay much more clearly. The area has been isolated well. I think we could have added a little bit of liquid dam, that is gingival protection barrier, in these areas, especially where the dam has been stretched and the papilla is exposed. That would have given a more ideal isolation now when I think in retrospect. But this is a decent isolation for us to work upon, right? So we have clamped the premolars. You can see that the clamp is extended over the premolars, so I can have good access on the six teeth I'm working upon, that is 1 3 to 2 3. Now, we go ahead and we first remove all that old restoration, right? We can see that that old restoration on 1 1 has been removed. I've also done the tooth preparation, like a class 3 kind of a preparation on 1 2. The 2 2 would be a class 4 because it involves the incisal angle. So, first of all, I want everyone to tell me uh, what is the difference between class 3 and class 4. I'm not going to project questions and give you options in this session. I wanted to keep it as clinical and interactive as possible. So please, guys, hit up your answers on the live chat box and tell me what is the difference between a class 3 cavity and a class 4 cavity. There are two main words, especially one single word that is most crucial in differentiating a class 3 from a class 4. So, hi Jaidev, good evening. So, I'm expecting a good answer from you. And the other people also let me know what is the answer in the live chat box, right? So, this is a kind of a class 3 restoration over here, a borderline class 4, I would say, for 1 1. The same with 2 1 as well. 2 2 is a proper class 4 kind of a scenario, right? I also did a small class 3 slot preparation kind of a thing. I also gave long bevels. If you see these long bevels over here at the cavo surface margin, we have placed long bevels in order to increase the surface area. Always remember, long bevels placed on cavo surface margins have to be at an angle approximately of 45 degrees. That is the burr which is being used, preferably something like a tapered fissure shaped diamond burr. So tapered fissure diamond burr you can use, or you can even use a tapered fissure, just a straight tapered fissure burr. You can just run it across that cavo surface margin in order to smoothen out those enamel rods, remove unsupported enamel rods, and to increase the surface area for micro mechanical retention, right? And this is to increase the effective surface area for bonding. Okay, so all these carious lesions were gently excavated with a water-cooled aerota handpiece and burrs, diamond burrs, followed by spoon excavators. Okay, so it is spoon excavators are probably the most handy instrument to use in such cavities where you want to stay as minimally invasive as possible, you can even use air abrasion in such scenarios where you can spray some alumina particles on these areas with some water and just remove all that unsupported enamel rods, and also to roughen the enamel and dentine in those areas. It will also help in increasing the surface area by making some microscopic porosities in the dentinal and enamel surface, right? So that is the removal of the old restoration and tooth preparation per se. We are expecting to keep all the arrested dentine and remove only the infected dentine. Please go back to our live series on ultra conservative dentistry. That was our last session, to get a good idea as to how to approach this affected dentine, right? You have chemomechanical caries removal, you have air abrasion, you have other methods such as fissurotomy burrs, you have minimal prep burrs, polymer burrs, smart burrs, and a lot more laser kind of treatments these days. Ultrasonic burrs are available in order to be as minimally invasive and protect that little bit of healthy dentine which is covering the pulp. All right. So let me just go back to our live box. I saw someone say pulp and then I think they just went ahead and deleted the comment. That's okay. Jaidev says that in class 3, the incisal angle is not involved. Shitters is saying that it's incisal edge. And Jaidev is again saying it is class 4 incisal edge is involved. Okay. So I like that you guys are thinking in that kind of an angle. But kindly remember that incisal edge involvement is one thing, but incisal angle involvement is another. So Jaidev, you were actually right in the first case. Vaishnavi, class 3 pulp is involved. Elise classification, right? So in Elise trauma classification, you have class 1, class 2, class 3 fractures, in which the class 1 would be just limiting to dentine enamel, and then class 2 would be extending up to dentine, and then in class 3 it would be pulp pulpal involvement due to trauma. But in cases of, yeah, class 4 is non-vital, yeah. But in cases of this, that is the GV Black classification, class 4 involves the incisal angle. Okay, that is the difference between a class 3 and a class 4. That is the reason why I wrote class 3 for 1 2 1 1 and 2 1, because her natural contours itself are like, in this I would say it's a borderline class 4 kind of a situation, but a proper class 4 in 2 2 in this area. All right. Great. So I hope that was helpful. So let's go on to the next step, which is acid etching. Uh, One thing I want to ask you guys: what is the difference between total etch and selective etch? Okay, so please drop that in the comment box until we complete this slide. Let me know what is the difference between total etch and selective etch. Okay. Next, so we are going to etch. In this case, we are doing a total etch of the enamel and dentine using 37% phosphoric acid gel. You can wait for approximately 15 seconds to 20 seconds. Remember, guys, over etching is bad. That is another answer I want from you guys. All the theoretical answers I'm going to be asking you. All right. So, what is over etching? What does over etching do to the enamel and dentine? Uh, how is it going to affect our final bond strength, right? So Jaydev, yes, total etch is enamel and dentine both, very good, but there is also some more content to it. There is little more depth to it. There are total etch adhesives, there are self etch adhesives, and there's selective etch technique. So what does selective etch do? Where is self etching adhesives used? I want those answers as well. All right. So we wait for 15 to 20 seconds until we get a frosty appearance in the enamel. Okay. We wait for that 15-20 seconds because we want those microporosities to be created, for those resin tags to be inculcated into these porosities. We need a good amount of porous depth in our porosity, right? So the canines were also selectively etched. That is only in those mesial sides we etched those areas in order to cover the surface stains and the defects. So there was just a little bit of enameloplasty which was done on the canines, but a slot preparation on 1 2 over here. So all those areas, the enamel and dentine were etched, right? You can see that phosphoric acid gel is first always applied over the enamel, and then we run it over the dentine, because dentine doesn't need to be etched as much. Otherwise it may lead to post-operative sensitivity. It can also lead to a lot of loss of bond strength. So it just needs to be etched for a very short time when you're using good single bond at per single bond kind of bonding agents, like fifth, sixth, seventh generation bonding agents, right? So this is the etching protocol. We wait, and then after 15 or 20 seconds, we nicely rinse it away. We rinse off all that etchant for approximately 20 to 30 seconds. Extremely essential to wash it off very well. Otherwise, the etchant can cause prolonged sensitivity to the patient. In this case, we are using the 3M at per single bond 2, which is a fifth generation bonding agent. Uh, After air drying, see, it is very important for you to air dry gently, right? It has to be a gentle air dry over the enamel and dentine. So what is the reason for that? Why should we only gently air dry after acid etching? Why shouldn't we apply a lot of compressed air? Why can't we apply with pressure? Can you guys answer that as well in the live chat? Right. So in this case, we used Atco single bond 2, which was scrubbed with an applicator tip. Remember, this applicator tip should be immersed in bonding agent, and it should be fully soaked in bonding agent before we go ahead and cure it, right? So it has to be completely soaked with the bonding agent and then scrubbed over the dentine and enamel in order to make those resin and the filler of the resin get into those porosities that have been created with our etchant. So after the etching has been done, we need those resin particles to get into those enamel micro tags, right? So we need to create those micro tags. So to create the micro tags or the resin tag is basically like you have a small hole, like a tube, that is a dentinal tubule, and it has been etched. So the smear layer has been removed. We are now entering in with a little bit of resin in order to create that dash layer. So what is that layer called? Jaidev thinks that dehydration causes the dentinal tubules to occlude. Not really. It doesn't really occlude. Something collapses though. So can you find out what collapses when you air dry too hard? But good attempt. I would say that dehydration completely would cause a loss of bond strength, especially with the newer adhesive bonding agents that are there in the market right now. But there's something that collapses when you hit uh, compressed air harshly over etched enamel or dentine. Tubules collapse. Yeah, that's pretty close. So we're speaking about collagen fibrils actually. The tubules are right there, but the tubules are made up of collagen, right? The matrix of the dentine is made up of collagen. So the collagen fibrils or the fibrils, those tend to collapse over, and then there is occlusion of the dentinal tubules, but not to the extent that there is. It's not because of dehydration per se. It is because of the collagen fibrils that are collapsing over the tubules, and they also lead to loss of resin tags, right? So yes, you are right when it comes to tubules collapse in a way that collagen fibrils collapse, but the tubules get occluded. Good. So this applicator tip is then scrubbed over the enamel and dentine for approximately 5 to 10 seconds or even a little bit more, after which you need to gently air dry, right? I want other guys to answer as well. Jaidev has been quite interactive. I want others to give your answers as to why should we air dry, gently air dry after applying the bonding agent. Why is it necessary that we have to dry the bonding agent after applying it? Why can't we just cure it like that itself, as we used to do way back when we were not taught that it is supposed to be air dried gently after applying the bonding agent? So there is a scientific reason to that, right? So let me know that as well. So after application of the bonding agent, we go ahead and cure that bonding agent for approximately 20 seconds, right? 20 to 30 seconds. Do not overcure, otherwise your pulp may get irritated, and do not undercure because then your resin wouldn't have been set completely. That is, your bonding agent wouldn't be set completely and it would still be moist, right? So then we go ahead with the layering of the nano hybrid composite resin. In this case, what we are using is something called as Solaire Sculpt, which is a light cured universal nano hybrid compactable or a packable kind of a composite. Let's just go back one slide. Jaidev thinks that to remove the smear layer, we are air drying it. No. I will wait for one more person to answer, after which I'll give the answer out. Why should we air dry after applying bonding agent? It is not to remove smear layer. Smear layer has actually been already removed while acid etching, right? So we start off with the layering technique. So it is essential that we cure every 2 increment of the composite, and that has to be for over a period of 20 seconds. Why is it necessary for us to pack it incrementally? We all have heard about polymerization shrinkage, right? There's a lot of shrinkage of composite that can happen due to polymerization. uh, Polymer, that is, our composite is basically a polymer made out of a chain of monomers. When there is any polymer involved, that chain, after curing, after its polymerization is done, it tends to shrink those links between the monomers over a period of time, leading to polymerization shrinkage. And if it gets contaminated with moisture during before polymerization, then the shrinkage will be much higher, the bond strength will be much lower, long term retention and marginal integrity will be lower. And that is the reason why I have placed a rubber dam. And even this small papilla which is protruding out is kind of bothering me right now. This was done about 3 years ago. So I am still kind of upset that I didn't have some liquid dam or gingival protection barrier that I could have placed on these papilla areas, that would have given me optimum moisture control. Okay, either way, it's a decent moisture control that we have obtained. So let's go ahead and layer this Solaire Sculpt layer by layer, sculpt that composite, place 2 increments. So at this stage, there are different ways to go about it. Either we can go with a freehand composite layering, which is you just take some composite, layer it freehand. You can use a little bit of mylar strips behind to create that palatal shell. You can even otherwise come up with a putty index. You can create a mock-up, which means that this preoperative evaluation that you have, you take this, or you can even take the first scenario that we had, take an impression, send it over to the lab, ask for a mock-up. So they basically add some wax over these areas, right? They can add some wax over these areas, and they will send it back to you, preferably white wax, so that they can carve it well. You take a repeat impression of that, and then you place it as a palatal wall, right? So you can create a palatal wall. You can just take that putty index that you have made from that wax up, and you place it over this area, cut the buccal side off so you can see only the palatal putty index, and then you can use that to create a palatal wall, right? So imagine a putty index which is giving you the contours of your final restoration to look like. So that would be great, right? That is something that I follow nowadays more. I follow the putty index, the wax up, and the mock-ups more because I realize the importance of the palatal shell being intact, and also for it makes our work much easier, quicker, more effective, more predictable. So that is what I follow right now. In this case, this was during my postgraduate days. I didn't have access to a lab immediately to create my mockup, so I just went with freehand composite buildup. But that should kind of tell you everything that involves composite layering technique. So we are going to pack composite in 2 increments. The Solaire Sculpt is a universal nano hybrid composite. It has self-polishing features. It's very quick to polish and finish. So the lifelike aesthetics that you get is extremely superior. It has high strength, provides optimized handling for sculpting of the composite. And one more advantage of using something which is like a nano hybrid would be that there is simplicity in shade selection. because they blend with the tooth surface very well. It's called as a chameleon effect, right? There's that unique chameleon effect which would create some amount of blending into the adjacent tooth tissue, right? Into the adjacent enamel. So the blending characteristics are very good when you're going with nanohybrid. So let me throw another question at you before I get back to my previous question. What is nanohybrid composite? How is it different from nano-filled composites like 3M Z350? Filtech Z350 is a nano-fill, a pure nano-fill kind of a composite. How does nanohybrid differ from that? Please drop that also in the live chat. Going back to my previous question, bonding agent, Vaishnavi says, should bond to tooth, we should do air dry. In order to bond to the tooth, we should do air dry. No, not again. Shishan says to avoid pooling of bonding agent. Very good. That is very close to what I was looking at. That's an excellent answer, but I'm looking at little more technical aspect than that. Let me just reveal it. So bonding agent has to be air dried before curing. A, to remove the pooling, obviously to remove excess bonding agent, but more importantly, we do not require the solvent. So, bonding agent has resin, which is the matrix, it has filler, which is the filler particles, and it has a solvent, right? So, the solvent is actually in order to, it is like a vehicle to carry your bonding agent over to your tooth and also to help in better adaptation and reducing the contact angle. So a solvent in this case would actually reduce bond strength. If you just apply it over there, the solvent would stay on the superficial layer and it would not be removed from the hybrid layer. Okay, so we are speaking about something called as a hybrid layer. Hybrid layer, go back again to our not the live session, we have it recorded in our recorded classes. We have a session in which we have discussed a lot about composites. So read up about why we need to air dry completely. So there's a solvent layer, there's something called as hybrid layer. It's there on a smear layer video, so look that up. Once we want to create that hybrid layer, the solvent is actually not a very uh, necessary component. Instead, it can hamper the bond strength. That is why when we air dry, we evaporate that solvent into air, right? So when you gently air dry on the bonding agent, you are helping in the bonding agent getting deeper into the tubules. You're also helping it to get evenly distributed, hence avoiding pooling, as Shishan said. And also, we are removing that solvent, which is not necessary for our hybrid layer, right? So I hope those 3 points are something that you take back from today. That is one, we don't want it to pool. Second, we want even distribution and the bonding agent to get a little deeper into our tubules. We want a very even distribution across our tooth surface. We do not want lumps of bonding agent here and there. So we want to distribute that evenly and have a uniform layer of bonding agent throughout the restoration, right? So that is the reason why we need to air dry and also to remove the solvent, as I said. Okay, so let's get back to this slide. Okay, so we are going to start packing that composite. So I've placed a little bit of composite in these areas. Freehand just took some in this case I used aluminum titanium nitride coated composite carrying instrument, that is by Hugh Freedy. It's called as XTS composite instrument, a beautiful instrument to be used. It comes in spade shape and you have different shapes, very thin, very accurate. I'm not sure if I have a. Oh yeah, this is the picture. So you can see this spatula shaped. So I have different shape. Let me get back to this. So before that, what I did was I placed preform matrices in order to create that mesial and distal contours, right? You get these matrices, sectional matrices, which you can contour it using a ball burnisher and then place it for initial contouring, not really to form the contact. This is just to contour those mesial and distal surfaces, so I get a better idea as to where we are going with this, right? Okay, I have another answer from Shweta, who thinks that nanohybrid is a combination of organic filler and a nano composite. Actually, there are range of filler particle, and that's nanohybrid. Very good. I'm very happy with this answer. I would say that that's quite close to accurate according to my opinion. So yes, there are different sizes of filler particles and different shapes of filler particles as well. So go back to your Sturdivants and read up composites. You will see that hybrids are a combination of both spherical particles and lathe cut particles in the traditional composites. Right now, what they're doing is they are inculcating different sizes and shapes, not just shapes, it's different sizes, that is microfilled along with nanofilled composites to create a nano hybrid kind of a composite. They also add a lot of different kinds of filler particles to increase the compressive strength, to increase the bond strength, to decrease polymerization shrinkage. So all those filler particles, when they're added, it becomes like a nano hybrid kind of a composite. Nano hybrid has superior aesthetics and at the same time very good strength, right? So nano hybrids are excellent when it comes to anterior aesthetics, but nano filled, I would say, is much better when it comes to compressive strength. Like 3M Filtech Z350, that is an excellent material for you to use as a universal restorative packable composite. So you can see that we have got the basic initial contours set up. We have a decent contact as well. I'm going to repolish these contacts and get back with some soft flex polishing discs in order to contour that. But before that, let's just fix our incisal angles and the edges well. So you can see that the 2-2 also, which was a huge defect, as seen over here, you can see in this photograph over here, it was a huge defect, has been restored in just about 2 or 3 increments. You are able to go from there to there, just with direct composites, no palatal wall built, no mylar strips used. It is just these sectional matrices and my instruments, right? So in this case, I've used a spatula shape, something like how they use your building tools, like the spatula that you have, the cement mixing spatula. So very similar to that. It looks like that. Very easy to use. This thing flexes up and down, so it's very nice and convenient to use. These are aluminum titanium nitride coated, so it's much better to handle, and sculpt composite doesn't stick to the instrument so easily. And also you can see that the lighting has changed from a natural lighting to an orange filter. And this is because the microscope has an orange filter in order to avoid the pre-curing of resin. We know that if we use white light, it can pre-cure composite during handling. So that is the reason why we use an orange filter, so that it is the opposite side of the blue spectrum, right? Vib gear, you know that, right? So you're going to the orange red spectrum from the Vib gear, that is the violets, that is our blue light. You're going to the opposite side of the spectrum in the visible light spectrum in order to avoid the pre-curing of our composite resin. So we have an orange filter which has been placed in order to prevent any pre-curing of the composite. All right. Shishan also is saying high pre-polymerized filler content. That is for the nano hybrid. Yes, yes, we have pre-polymerized filler particles. That is, the filler particles are already polymerized to a certain extent. There are small spherical molecules, globules is what they call it. So that also adds up to the nano hybrid answer. Very good. So now I'm going to switch my instrument from aluminum nitride titanium coated composite handling instrument to a modeling instrument, right? So I'm going to model my composite using something called as a Compo Roller, not readily available in India right now because Kerr is no more in India, but it's an amazing instrument if you want to sculpt those line angles very well. So I use that in the proximal contact areas to get my line angles right. So you see that the tip is very thin, right? So you can just place it in the contact areas and lift it up towards the central incisor where you want to create the line angle. So what you get effectively is a small kind of a line angle that can then be polished and finished using your Soflex discs, right? Next, I'm using something like the Optra Sculpt. Compo Roller has a disc-shaped tip. You can hit up Optra Sculpt and see it on Google. It's a very nice instrument which can be used for adaptation of composite and blending of the resin onto the tooth surface. So in this case, I use the Compo Roller with the disc-shaped tip to blend in that composite into the cervical and the middle third. So this, now I'm getting back to orange. I've removed the orange filter and going back to my normal light because I've done the final curing. You can see a lot of flash and excess of composite on the rubber dam, a little bit over here on the tooth surface as well. A lot of excess over here. So because this is a freehand restoration, there will be a lot of excess of composite that you have to remove it. So get your coarse grid pop-on discs by Soflex onto the mandrel. So you have a mandrel. This disc can be reversed as well in order to gain better control over your polishing. So you can use that to finish the composite restoration. So first, it's the finishing that we are doing. Um, Also, let me just go back one or two slides. I want to stress upon something that I did over here using this instrument. You can see the line angles that I've placed over here. They have been sharp initially, right? You can see the sharp line angles that I then rounded off on the distal surfaces, and I further on rounded off when I was using the Soflex. This is based on a concept called as visagism. All right, you spell it as VISA like visa and GISM like gism. Right. So visagism. Does anyone have an idea as to what visagism is? How is that applicable to anterior aesthetics and restoration of teeth in general in anterior cases, right? Anterior rehabilitation. So, what is visagism? I'll wait for that answer for you guys in the live box. So once we placed that Soflex discs, we started removing all that flash in the gingival sulcus area. We can use even a number 2 surgical, no, sorry, number 12 surgical blade, which is a curved surgical blade, in order to remove that little bit of flash in the cervical area, right? And then we go on to our other much more finer discs. You have Soflex. This is the coarse one. You have finer discs in the colors of orange, and you have pink, and you have other lighter colors. The darker colors are always coarse, the lighter colors are always finer. So with the finer Soflex discs, this is what I was able to achieve. You can see that I've given a more rounded incisal angle in her case, which is related to visagism. Yeah, Jaydev, it is related to shape and personality. Very good. So that is something of a more something I want you all to know, so that you don't get stunned when you look at this in your NEET papers. Some a random foreign alien kind of sounding word, because we have never heard of this. Even I bumped into it only during my MDS. So it's great that Jaidev knows what it is during BDS itself. It is related to shape and personality. So concept of visagism is actually in order to it is a principle. There are a set of principles of visagism. You can just Google it and you'll get a lot of articles on it. So let me just give you a brief highlight as to what it is. It is a set of principles which have been inculcated into our dental practice in order to ensure harmony between the patient's personality, that is, are they sensitive or are they aggressive, are they a little bit more timid, are they shy, are they more hyper kind of people. Actually all that has a lot of correlation to the line angles, to the shape of the teeth, to the contour of the teeth, to the size of the teeth, to the even the point angles and the bulge, the cervical bulge. There are a lot of correlating traits between the personality of the patient and the small little uh, teethy, features that we have. Apparently, it has been researched that if we change these line angles, the personality traits of the person also changes over a period of time, which is quite surprising and quite interesting to know that there is a lot of connection between just those small line angles and point angles of teeth to the personality of the patient. So apparently sharper incisal angles and more oval kind of personalities reveal a person who is more aggressive, more dominant kind of personality, and the rounded internal contours, smoother outlines, and a more kind of um, I would say a delicate line angle or a delicate kind of cavo surface margin would be in those cases who are a little more timid and shy, right? So it is apparently important for us to also understand the personality of the patient before we do these restorations, because each and everything we do affects their personality, is what visagism speaks about, right? So in this case, we gave smoothly curved incisal angles, and they were oval teeth, so it made more of a good kind of a camouflage in order to decrease the length and make it look more broad. And also with a longer interproximal contact and that is also in accordance with the principles of visagism. So there are a lot of personality traits that was studied of the patient and then incorporated. Sounds a little fancy, but I want you guys to know about it so that you are prepared when it comes to your NEET exams, right? So this is the final outcome. So we have reached from here, right from the first slide, we can see that that a lot of defective composite restorations, there's old restorations, there's surface stains, and there's a huge class 4 restoration on 2.2, which have been completely restored now back to normalcy with this composite buildup which was done freehand, right? There was little bit of midline centering issues for her, which were there. And that is the reason why we gave the option of orthodontics as well for her. But she just wanted some amount of anterior aesthetic rehab itself. So we did the post polishing of the restorations using the medium and fine grit 3M discs, followed by aluminum oxide impregnated silicon points and cups. So you have these polishing kits, especially by Shofu. They are brilliant. You can use those aluminum oxide. This is the polishing particles that have been impregnated into these silicon points that get abraded, doesn't damage any tooth structure. It just gets abraded, self-limiting points and cups. And you can appreciate that the light reflection from both the sides, right? It is very symmetrical. You can see the line angles, you can see the long interproximal contact that I've given. It's also centered with the papilla. These little bit of bleeding cuts are due to the discs that will just heal in a day or two. I wish I had more angles for me to show, probably from this angle as well, for me to show this class 4 over here. But I think this gives you a brief and a good overview as to how to restore uh, anterior aesthetic cases using freehand composites. So I have two, three questions for you guys. Before that, let me just tell the future treatment plan. In this case, we also planned for a post and a crown. In this case, we were using minimally invasive pin posts from Dentapreg, followed by a crown because this was endodontically treated. This was a temporary approach. Also, I wanted to correct a little bit of that rotation of the teeth, which you can see over here. It's slightly rotated. So I corrected that as well with the crown. So that has not been documented in this. This is just limiting to anterior aesthetic rehabilitation. We were also discussing whether we should go ahead and change this incisal angle to a more sharper incisal angle to mimic this. So a little bit of this polishing over here also would have helped. Apart from that, a decently restored anterior case. And we all know that resin-based restoratives are increasingly being used in dentistry because of their aesthetic quality, good physical properties, and also their ease of use, in the sense that they're quick, they are single appointment. You do not require a lot of instruments or materials. You do not require expensive cements. You just require a good composite and a good um, bonding agent to restore such a case back to normalcy. So nano filled and nano hybrid composites were more recently introduced in order to provide a material which has excellent polishing with superior gloss and polish retention. That is the reason why we have been using nano hybrid or nano filled composites in this era, right? So let me just pass on a question or two for you guys. What is the difference between using a fifth generation bonding agent and a sixth generation bonding agent? What is total etch? I think total etch we have already discussed. So just give me the answer for fifth. What is the difference between fifth generation and sixth generation bonding agents? Also, what is the ceramic etchant which is used? So we know that the enamel etchant is phosphoric acid. Can someone tell me what is a ceramic etchant used in order to etch ceramic surfaces? So that's another question for you guys. That is, what is the difference between fifth and sixth generation bonding agents, and what is the ceramic etchant or the porcelain etchant that is used? Right? Any other questions you guys want to ask me? You can feel free to go ahead and ask. Uh, if it was a posterior composite case, I would have used more amount of matrices, like a better matrix, like a sectional matrix with a ring in place in order to place it better, in order to place the contacts better, because this was an anterior case and our access is very good. We could go ahead and do a freehand, but in a posterior case, I would have used a good sectional matrix with a ring. So Prerna is saying that it's hydrofluoric acid. Very good. What is the concentration though? Concentration of hydrofluoric acid. Shishan is saying fifth generation is two step, sixth generation is one step. Fifth generation is a one bottle plus etchant. Yes, partially right, Jaidev and Shishan. But what is two step and what is incorporated in that one bottle? Jaidev, sixth generation etch, primer, combined, and adhesive. Okay, all right. I'm just waiting for others to answer. Okay, so we have Shishan saying that fifth generation etch and primer is in one bottle and bonding agent is separate. Okay, are you sure? Are you sure? Sixth generation all in one bottle. All in one, huh? Are you sure again? See, there's a lot to do with bonding agents, right? I think we need to keep a separate session just on bonding agents. Also, let me know in the live chat box what would you want to see next in the case presentation. Would you want to see endo or would you want to see restorative? Sorry, mixed up. Yeah, yeah. You are a little mixed up. So, okay. So let me just get back to the bonding agents classification, right? Because it's extremely confusing for any of you. So let me just make this simple, uh, extremely simple, right? So let's start off from the fourth generation, that is the total edge. So we have the fourth generation in which we have one of the best bond strengths which have been achieved in all the bonding agents, approximately 18 to 25 megapascals of bond strength. Before that, in the first, second, and third generation, it was just approximately 2 to 10 or 15 megapascals of bond strength, which was achieved to dentine. All whatever we're speaking is to dentine, not to enamel. The enamel bond strength is much higher. Can someone tell me what is that? It's sixth and seventh. Okay. So let me just break this down for you. So fourth generation is total edge. Okay. Remember these terms that I'm saying. Fourth generation is total edge. Fifth generation is a single component hybridization kind of a technique where we have two components. Sixth generation, we have multi-step, multi-component, self-etching, self-priming. Okay. In seventh generation, you have single component, self-etching, self-priming, and it also bonds to metal. Okay. So let's go back. All right. From the fourth generation. So fourth generation is three step, as I said. Okay. It is etch and rinse. Okay. So there is an etchant, which is 35% phosphoric acid. There is a primer, which is a PCA copolymer. You have HEMA, that is HEMA. You have a little bit of water as well. So you have a primer, and you have a bonding agent such as BIS GMA, or you have UDMA, all these bonding agents. So that is fourth generation. That is, you need to etch first using phosphoric acid. Then you need to use a separate priming agent, and then you need to use a separate bonding agent. Okay, is that clear? Fourth generation is three-step: etch phosphoric acid, prime with your HEMA and water and PCQ, and then you have that is a PCA copolymer, and then you have the bonding agent, which is BIS-GMA. All right. Next, an example for this is Scotch Bond Multipurpose by 3MESPA. Okay, Scotch Bond Multipurpose. So there are different Scotch Bonds. There's Scotch Bond Multipurpose, which is fourth generation bonding agent. Okay. Next, we have the fifth generation bonding agent, in which we have one etchant, which is separate, and then we have one bottle, which is combined, that is the primer and bonding into a single bottle. All right. So it is a self-priming bonding agent, you can call it. So the primer and the bonding agent are both in one bottle. So the HEMA and the BIS-GMA are both in one bottle itself. Is that clear? All right. I want you all to be very clear with this. Fourth generation, just say yes if you guys are clear, or if you have a doubt, stop me, because please understand these concepts. They are extremely important when it comes to answering your NEET questions. They can ask you about the different copolymers which are used in primers. So please read that up. You have polyalkanoic acid copolymer, and then you have phosphate monomers. You have a lot of different kinds of. There's something called as MDP monomer right now, which is the most, I would say, recommended component for a bonding agent right now. Okay, good. So if you guys are understanding, then let me go ahead. Fifth generation is a separate etchant, primer and bonding into a single bottle. So it is called as two-step, all right? It's not three-step. We are skipping primer, going directly with primer and bonding in a single bottle. So this is also etch and rinse. You cannot etch and stop and go ahead with bonding agent. You understood? It is called as etch and rinse. All right. Next, you also have a fifth generation in which it is self etch, which means that you have an etchant, which is your phosphoric acid, and you also have a primer and a bond which has a little bit of 10 MDP polymer, which also has some amount of self etching properties. Example is clear fill SE bond. All right. So that is fifth generation, right? So let me just go back. You have fourth generation, which is etchant, bonding agent, priming, and then bonding agent. You have fifth generation, in which the primer and the adhesive are in one bottle. Next, you have the sixth generation, which kind of overlaps with the fifth generation, where there is self-etching primers which were introduced. So the main idea was, can someone tell me actually why they were trying to avoid the etchant separately? Why did they try to put that also into the bonding agent bottle itself? So they had the primer which had the etchant. So there were self-etching primers which were used. So can someone tell me why they used self-etching primers and not phosphoric acid etchant separately? Also, if you see, that is the reason why the bonding agent, the bond strength slightly dipped. It became around 18 megapascals as soon as we got the self etching primers over there. With the fifth generation, we were able to achieve 20 to 24 megapascals. That is with your prime and bond NT or your single bond universal kind of a thing. So can someone tell me? I'm waiting for the answer. So where to study the recent advances? Recent advances of what? Composites? If you want to know the recent advances in composites, we can have a separate session in that. Okay, going back. All right. So we have our fourth generation covered. Fifth generation, we have our primer and adhesive in a single bottle, and our phosphoric acid separately. In our sixth generation, we have two types. We have either an acidic primer and an adhesive, or we have acidic primer and an adhesive with a catalyst. Okay, so that means that there are self-etching primers. Okay, so I asked that question. I was waiting for the answer. Bond strength is increased if you remove the etchant? No.
Shishin Bandhu says smear layer modification instead of removal. Very, very good. Very good. That's very close to what I was expecting. Okay, I'm just waiting for the answer a little more. Next, let's go to seventh generation. So, as we said, sixth generation has the self etching primer and a separate bonding agent. Now, the seventh generation is a self etch. Uh, you have light cured and dual cured in both, in which there is an acidic primer and an adhesive in a single bottle. So, all in one bottle. Okay, acidic primer and an adhesive in a single bottle. So you do not need another etchant per se, but you can do selective etching using your phosphoric acid only on enamel, but don't etch dentin. Okay, so in seventh generation you can do either just using the bonding agent on all surfaces, but advisable to use etchant only as a selective thing on the enamel surfaces to create your microporosities, and avoid etching dentine because you have your self etching acidic primer itself in your bonding agent bottle. So these are the different adhesive components, right from fourth generation, like your Adpers Scotch Bond multipurpose, with three bottles, phosphoric acid, primer, and an adhesive being different. We also have the fifth generation, in which we have the adhesive and the primer in a single bottle, and a phosphoric acids separately. You have sixth generation, where you have self-etching primers such as Adper Scotch Bond SE or Clearfill SE. SE, wherever you see SE, remember self-etching. Self-etching primer. Self-etching in Clearfill, or even Scotch Bond SE is self-etch adhesives. So all these are self-etch adhesives. So the primer itself will etch. We know that the etchant is to create those microporosities. Primer is to remove that water. It drives the bonding agent deeper within the dentinal tubules, uh, and the bonding agent is to create those resin micro tags and create your hybrid layer. So in fourth generation, you were able to achieve the highest amount of bond strength because the etchant, bonding agent, and the primer were all three separate components. So you did not have fusion of any of these. As we went higher up, that is fifth, sixth, seventh, we made the process relatively simpler, tried to inculcate everything into a single bottle with a combination of chemicals, but we were losing out on a little bit of bond strength. That is the reason why your seventh generation bonding agent gives you around 18 to 24 megapascals, while your fourth generation gives you a higher predictability like 20 to 25 megapascals, right? So that's that. Then we go to sixth generation, which has acidic primer, as I said, SE. Then you have seventh generation, which is examples are like Clearfill DC bond. You have the Xeno 4 DC. You also have the uh, 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 Adhe SE1 by Ivoclar. You have Clearfill S3 bond. You have OptiBond all in one. All these are acidic primers with an adhesive, right? So you don't need a separate etchant. You just need that acidic primer and the adhesive. Even with the sixth generation, you can just use the acidic primer and the adhesive, but it is not as very effective as the sixth generation, right? Okay, so which is best generation to use, sir? Jaidev is asking that. So yes, as I said, fourth generation has been proven to be one of the best when it comes to bond strengths if used correctly. That is the difference, right? So there is a lot of technical problems when it comes to using our Scotch Bond Universal or our Curare Clearfill bonds, that is our fourth generation bonding agents. There's a lot of variabilities in the bond strengths that can be achieved because each and every step can kind of affect your bond strength. Uh, that has been tried to it has been tried to decrease as much as possible in your sixth and seventh generation, that is your Adper or your Clearfill S3 bond or Clearfill SE. By all these are by Curare. You also had your older bonding agents in fourth generation, which is the best. So if you ask me what is the best bonding agent to use, it has been proven by a lot of restorative dentists that OptiBond FL, that is the Total H fourth generation bonding agent by Kerr, OptiBond FL. Also, the sixth generation Clearfill SE bond by Curare. These two are extremely good when it comes to the bond strengths that have been achieved. So yes, which is the best generation? If you ask, I would say fourth generation. But if you ask which brand or which particular product to use, it would be OptiBond FL by Kerr and Clearfill SE bond by Curare, which is fourth and sixth generation respectively. You can even use the fifth generation OptiBond Solo Plus by Kerr. That is also excellent. That, but you need a separate etching for that, right? Reduced application time. Uh, that is for smear layer modification. Yes, yes. So as I said, yeah. So the reason why we try to skip, one of the reasons being reduced application time, why we skipped etchant. The second being smear layer modification. Yes, we do not really want to remove all that smear layer, which is essential in creating a hybrid layer. We want to retain a little bit of it to create a higher bond strength. So yes, it has been used. Etchant has been removed for that purpose, but there's another very important purpose. That is because when we are using in the deeper portions of dentine, our etchant is going to create post-operative sensitivity. It's as clear as that. It's as simple as that. The more deeper you go in the dentine and you use your etchant, it is going to create some amount of post-operative sensitivity. So to reduce that post-operative sensitivity, etchant was incorporated into the bonding agent, so we do not over etch. To reduce all the effects of over etching, they removed that etchant and put it off into the bonding agent and made self etching primers and self etching adhesives. That is the reason why etchant should be used very, very cautiously. Do not over etch. All right. If you over etch, what happens? I was expecting an answer for that. What happens if you over etch enamel or dentine? That would be the last question for today. I want you all to ponder upon that. Why should we etch dentine only for 20 seconds and not more than that? Okay. So frosty white appearance is something we need, Vaishnavi. So we want that frosty white appearance on the teeth in order to know that we have etched that surface. And that is naturally created because of those microporosities and dehydration, selective dehydration in those areas, demineralization in those areas. But that is not the answer. Why shouldn't we over etch dentine? It is something to do with the demineralized zone. All right. That's a small clue I can give you guys. Okay. So we have Jaydev says it will irritate. Shishan says that dentin overetch causes collagen collapse and opens the tubules. No. Jaydev says it will irritate. Yes, that's what I said. It will increase post-operative sensitivity. But there's another main reason why we shouldn't overetch. I'm waiting for the last answer. See, over drying causes the collapse of that collagen network, right? If you over dry, if you dry your collagen too much, if you dry your, after etching, if you dry the enamel or dentine too much, then it will lead to collapse of the collagen fibrils. And also, as I said, lower bond strength, okay, if you over dry it too much. And there's also something called as matrix metalloproteinases. So these are endogenic enzymes, right? So these get liberated and activated when you over etch, when you over dry, sorry, and they get into your bonding agent hybrid layer. And this can lead to significant loss of dentine bond strength over a period of a few months itself. So MMP, all right. So just write all these down. I'm giving you few things to understand and study. Very important when it comes to NEET. Matrix metalloproteinases have to do with bonding agents a lot, and they've been repeatedly asked what is the effect of MMPs over your hybrid layer. So please read this up, okay? But I'm still waiting for the effects of over etching. Discoloration, removal of hybrid layer, all those are smaller reasons. That those are going to lead. It is going to lead to removal of hybrid layer, but discoloration in the long run, yes, probably, but not really. See, one of the main things is that when you over etch dentine or enamel for that reason, especially enamel when you over etch, what happens is that there is something which happens. I want you all to just think about it once again. What is enamel made out of? They are made out of enamel prisms, right? So something hitting your mind right now, something striking up. Uh, so we have Prabhavati saying that it can be rough uh, and compromise the longevity of restoration. Yes, yes, it does cause roughness. It does cause deterioration of the restoration in long term, but there's more to it. See, one of the main things what happens when you over etch is that it can create insufficient penetration of bonding agent. You understand? So what happens is it was studied that when you dry excessively as well, drying excessively will lead to collagen collapse, and it will impede penetration of the bonding agent into the dentinal tubules. Is that clear? When you over dry after your etching, it leads to collapse of the collagen fibrils, that is the matrix of your dentine, and that will lead to impeding the penetration of the bonding agent within the dentinal tubules. So it won't go deeper. But if you over etch, that is, you leave the etchant for a longer time, then what happens is there is voids which are left under the hybrid layer because the bonding agent is not able to reach effectively, thus leading to loss of bond strength. And also there's something which happens to the enamel. And I'm waiting for that answer. Okay. So one more thing which can happen is it can decrease the surface hardness of your tooth itself. So what happens is when you over etch, phosphoric acid is a very potent, strong acid etchant. So if you over etch enamel and if you over etch dentine, what happens is you're decreasing the surface hardness of your enamel prisms. So eventually it can lead to cracks being formed within the enamel surface. It can lead to, as this one said, Prabhavati said, it can lead to increased surface roughness. Okay. And most importantly, it can lead to, as I said, reduced surface strength over a period of time, surface hardness of the enamel and dentine. The prisms become much more weaker, because of which there is cracks or there can be some amount of marginal deterioration over a period of time due to over etching. Okay, is that clear? So if you see that there are various studies which have been done uh, with 37% phosphoric acid being applied for 10 seconds, 20 seconds, 30 seconds, and it's been found that 15 to 20 seconds has been ideal for creating that microporosity for your primer or bonding agent to enter inside and create the hybrid layer. If you etch longer, it can lead to, as I said, decreased surface hardness of the enamel surface. It can lead to creation of voids under the hybrid layer because now the dentine bonding agent is not able to traverse through that tubule very effectively. All right. So that is the main reason why we are looking at over etching only for a brief period of time of only 15 to 20 seconds. And then there is obviously the fact that you shouldn't over dry. You can just use a small tissue paper or a small a sponge like or just a cotton pellet in order to dab that area. So after your etching is done, you can just use a little bit of cotton pellets or very gently air dry. Even air dry is not absolutely indicated. If you look at the, for example, if you look at the 3M at per single bond tools manual, they tell you to use a tissue paper to just wrap it around the tooth surface and just dab it over there, or you can use just a cotton pellet, and the dentine should be left moist when applying the bonding agent. Especially with the fifth generation, sixth and seventh, we are looking at a moist dentine to place our bonding agents, even with the fourth. But in the fourth, you have your primer to remove the water for you. Over here, you do not have a separate primer. These are all self-etching primers which have been introduced after sixth generation, because of which you need to make sure that you are completely drying, not completely drying the enamel and dehydrating the enamel and dentine. All you have to do is just dab it and remove the pooling of water. It should remain moist while placing your bonding agent. Do not forcefully dry. Do not over dry enamel after etching. Please do remember that it is an extremely important concept that I don't know why people don't really teach. Is it reduced surface hardness? Yes, Pravavati, it is reduced surface hardness as well. Please, sir, take next session on bonding agents. Yes, I'll be glad to do that. Bonding agents is a vast topic. There's a lot that I need to talk about in a very less time. But I want suggestions for more topics. I have briefly covered bonding agents right now, so we can keep a proper lecture on that. But I was actually looking for suggestions for case presentation. For my next case presentation, would you want it to be endo or conzo? Quickly tell me, and let's wrap this session up. Would you want endo or conzo? And I'll give you two, three topics. Please choose from each. What would you want for the next preparation? That is your next presentation. Uh, Endo, I have a couple of topics in case presentation that I can do. We can do revascularization, extremely interesting topic, very novel technique using PRF, that is facial rich fibrin. We can create dentine again, right? We can create dentine like layers again. Some amount of closure of the open apex can be done using PRF, that can lead to regeneration and revascularization. We can even do posting cores. You want to learn more about fast posting core, or you want to learn more about fiber posting core? Do you want to see a case on fragment reattachment, like a trauma case? So I have a trauma case. Shishan wants endo, Jaydev Vaishnavi wants conzo, Prabhavati wants endo perio lesions. Uh, Case presentation, not yes sir, regenerative Jaydev. Case presentation on endoperio, I don't have a ton of cases that I have documented on endoperio, and it requires a multidisciplinary approach. So there's a lot of theoretical basis to it, I would say. So this is just for the case presentation live series. So I'll just tell few topics, just write whatever you think is right, whatever you want to listen to. So the first topic would be endo, that is management of C-shaped root canals in mandibular molars. Would you want to know more about C-shaped root canals? Would you want to learn more about them? What would you want to see my cases on C-shape? Let me know. Another good topic I have is fractured fragment reattachment. So a trauma case where a guy just fell down, broke his tooth into half. That is at near the cervical third. It was a crown root kind of a fracture, or probably just a crown fracture. It was extending slightly towards the root, which we could reattach using the e-glass fiber post, anatomic post. We used Everstick in order to bond that fragment back to the tooth. So we can do that, or we can do. a surgical microsurgery? Would you want to see a microsurgery with root end dissection and apicectomy and retrograde filling, or would you want to see a laser pulp capping with MTA as a case presentation? I also have a couple of cases on apical closures using apexification and apexogenesis, not apexogenesis, but PRF revascularization. I have a couple of cases on uh, open apex management, pulp capping management, C-shaped root canals, reattachment of broken fracture fragment. I also have surgical management of root resorption, root perforation, surgical management of root perforation using MTA as well as magnification. So I have those. So I have a couple of topics. Prabhavati wants fracture. Jaidev wants to learn about apicectomy. Okay, guys, so kindly decide on one. Regeneration looks to be slightly more interesting. Two people have told me regeneration. So, okay, I think let's go with PRF then the next time. We can probably do that in the next topic. Okay, great. Done. So I think we had a fruitful session today on just a little bit of direct composite restorations. You can see the various steps right from pre-operative evaluation, treatment planning. We discussed the various options, ceramic veneers, or we are looking at crowns, or we're looking at direct restoration. So direct, indirect. We also have direct, indirect like techniques, semi-direct techniques, where you can use direct composites, but chair side, so you can fabricate it on a die. So you can read about that as well. Then we did the isolation, magnification, and then removal, tooth preparation. We spoke about visagism. We spoke about etching, over etching, over drying. uh, just to recap, we also spoke about bonding agents, the different classifications of bonding agents, what is the bond strengths with each bonding agent. We also spoke about why it is necessary to just use a cotton pellet and not completely air dry the enamel and dentine. Just use a cotton pellet, dry it a little, keep it moist. You can see that when I was applying the bonding agent, I left the tooth as moist as possible, but without any pooling of water or GCF or blood or anything, right? So then we spoke about layers, why 2 increments is required, what is polymerization shrinkage, how does that happen, what is the nanohybrid component, where is nanohybrid used more so, what is the difference between nanohybrid, nanofills. I was happy to see interactive answers from you guys. That's great. Very good, accurate answers when it came to nanohybrid and nanofiller, which was quite surprising because these are relatively newer materials. Then we saw that we used sectional matrices in order to create that initial contour, and then we layered using different instruments. We had the XTS from Hufridi, Compo Roller from Kerr, and then we used Softflex discs from 3M in order to do the finishing, polishing, and this final result that we were able to achieve in just a matter of around 1 hour or 1.25 hours. So yeah, so I hope that we can wrap this session on a good note, and I think everyone is more inclined towards revascularization. Jaidev is also saying trauma. Okay, I'll do one thing. Let me just go back to my slides, see what would be more apt for you if you want to do fracture fragment reattachment. I can do that, or regenerative. Great. So thank you guys for watching and staying tuned for this 1 hour on anterior aesthetic rehabilitation with direct composite resins. Right? Thank you for this interactive session. Any doubts, please feel free to contact us. Okay? Great. Happy weekend, guys. Take care.